Hey guys, my name's Danny. I'm one of the third year, to be fourth year residents. Welcome to Mount Carmel. It'll be exciting to get to know you guys over the next year and some of you over the next 5 years. I'm talking about agitation and delirium. We deal a lot with this, and this is something that, if I want to embark anything on you, is not to take lightly, particularly when you're on the floors and you're early on and you're getting phone calls from nurses, because you get a fair amount of calls regarding agitation or delirium in some sort of setting on some sort of scale. So this is not something just to write off and attribute to it just being a kind of old grandma who's acting crazy, being in the hospital, just having surgery. You really need to, take it seriously. Treat everyone like there's an event going on, and then if you've ruled out everything, then you can kind of come back and say that maybe she is just grandma or granddad is just delirious. So we'll start with an overview. I'm going to give some definitions of what delirium and agitation are. We're going to talk about causes of delirium and agitation and what are kind of promoting factors for patients to become delirious or agitated. Next, talk about the workup of delirium and agitation, the treatment of it, and I'm going to give just a brief case example at the end. The case example is more to kind of illustrate because there are so many different causes. Case example at the end is more just to illustrate kind of what is your thought process when you get a phone call or a nurse approaches you on a patient who is delirious or is agitated or is confused. So first, kind of straight out of the textbooks, and guys, I took a lot of this out of Marino's ICU book. I think it's really a great source for a lot of things, particularly when you get in the ICU. But a lot of the stuff for ICU care does carry over to stuff you're doing on the floor. So I recommend at some point, either in your first or early second year, you pick up a copy and start reading parts of it because it is pretty darn good. So the definition of delirium by the textbook is acute behavior fluctuating over a 24-hour period, including difficulty focusing or maintaining attention and disorganized logical or incoherent responses. Agitation is state of excessive psychomotor activity accompanied by increased tension and irritability. These definitions are pretty broad, and you'll see when you see these patients that they can present in a wide variety of ways. You can have a patient who's delirious that just has some minor confusion, just doesn't really know where they are. They're kind of speaking incoherently or not making much sense. They could not know the year, not know the time, just overall, just it showing odd behavior. Agitation can vary a lot from just abnormal movements, feeling of restlessness to really complete and utter movement and even kind of dangerous activity towards themselves or towards others. So there's a wide range of behavior that's demonstrated, and in a way, once you're taking care of patients, and you've probably seen them in medical school, is it's one of those things that you kind of know it when you see it. That there's not a great overarching definition of either of these, but you really know it when you see it. It's very common in ICU patients. I know when you're first starting out, you guys will not be caring primarily for ICU patients, but it's very, very common in that setting. It's most common in patients that are either ventilator dependent, these are the patients your seniors are taking care of, or elderly post-operative patients. And this describes really almost every single patient we're taking care of on a surgical service. So our patients just in general are more prone to suffer from either delirium or agitation. My takeaway number one, and I said this a little bit at the beginning, is delirium or agitation is due to an acute medical event until proven otherwise. And when you get this phone call, you have to take it seriously. You can't just blow it off until you've ruled out the very common cause, or I guess some of the common causes that we would see on a surgical service that could cause delirium. And what are those causes? I mean, there's a bunch. It's not something to memorize, but just think of, I put some of the more common ones that we would see, such as sepsis or infection. Could it be something inherent to the brain, such as a stroke or a traumatic brain injury, encephalopathy, hypoxia or hypercapnia, hypoglycemia? I don't know if you've ever seen a patient who is hypoglycemic. They can have very, very erratic and strange behavior. Medications, heart problems, liver problems, thyroid issues, adrenal insufficiency. You name it, almost it can cause delirium and agitation in a hospital setting. Some of the factors that contribute and why patients in a hospital are more prone to become delirious or agitated. Patients that are advanced of age, which is very common in many of our patients in the hospital. Patients that are sleep deprived. Well, I haven't really heard of a patient who's ever felt well rested in the hospital just due to the beds being uncomfortable, the fact that they're uncomfortable due to their sickness or surgery. They're getting woken up at all hours of the night by nurses and staff and others. Patients in pain. Um, Most of our patients have some degree of pain, whether from the acute event that they're in the hospital for or whether they've just had surgery. Prolonged bed rest. Surgical patients don't like moving because it hurts. Um, Also, encephalopathy, some sort of inflammatory response that's causing SIRS, and drugs, um, or factors that help promote delirium and agitation in our patients. And as you can see, most of our patients that we've taken care of have at least one, if not multiple, of these factors that contribute. So for the workup, said this is providing more of a basic guideline and guide for you when you get a call like this, because I'm not going through the workup on all the stuff. Okay, this is going to be covered in some of the other um, intern lectures that some of the other residents are going to give you. This is also things that you've learned in medical school. These are also things that you're going to learn in your time here as a resident. So I'm not going through this workup, but I want to provide you somewhat of a framework to give you an adequate and thorough workup of a patient. So what do? You get the phone call, okay, on the phone when you're on the when you're with the nurse, or if they approach you on the floor. Get some of the history. What is, and most of the good nurses are going to call you and give you some of this when they call, but that's not always. So get some of the history. What are they here for? How many days have they been here? What post-op day are they? What surgery did they have? Events surrounding the change. Is this something that the patient was fine up until 10 minutes ago and all of a sudden they've changed? Is this something that's maybe gotten worse over the course of the day? Have they been confused for a couple of days now and that's acutely worsened? What are some of the events surrounding it? Are there any medications that have been given recently? Kind of get the recent events that have the recent events about your patient. Always, almost anytime you get a phone call about acute change in a patient, whether that's from a mental status or otherwise, ask about your vital signs and your urine output, because that tells you kind of how stable the patients are and have those changed recently. Second thing that's important is go see your patient. Okay, are they oriented? Ask them. What is your name? Where are you? What year is it? Who's the president? See if they're oriented. See if that has changed. Do a physical exam. Check their wounds. Look at their incisions, their lines. Do a neuro exam. Look up or ask about any recent labs or changes in their care. Check the medications that were given recently. After you've done your homework there by seeing the patient, talking to the nurse, looking in the computer, getting a little bit more of the history, talk to your senior. We're always open and available. You can even talk to us before you go up and start all this stuff. And especially early on, we like to know what's going on in the hospital and help coach you guys through. But make sure you're communicating with your senior, okay? If the senior's not around, or if it's an acute issue and you feel like you need to talk to the attending, that's always okay as well. But usually you want to run this up the chain. Next, we're talking about what are you going to do for a workup. Common things that will be ordered or looked at are chest X-ray, EKG, lab work, including a complete blood count, basic metabolic panel, urinalysis, or an ABG, and I throw a CT head. But there are many other labs, imaging, whatnot that can be utilized as needed based on what your exam, what you're seeing the patient, what people have told you about them. You will get in the habit, and it's not uncommon for whatever acute problem that a patient shows. Chest X-ray, EKG, CBC, BMP, UA. That's kind of in your grab bag of stuff that you can throw out that can be done pretty quickly, easily, and give you a lot of information about potential bad things that can be going on with the patient. To treat delirium and agitation, ultimately, if there's an underlying cause, treat that cause. Okay, I'm not going through that here because it's a lot, but if you uncover something, treat it. You can look at the drugs and you can remove some of the deliriogenic drugs that they're on, or the drugs that are agitating. Those are often anticholinergics, dopaminergic, serotonergics, or GABAergic drugs. Examples of those are your patients on any antidepressants or antipsychotics, or they've newly been initiated on those. Reglan is one, which is a promotility agent that we use not uncommonly on the surgery service. Is a patient on Reglan, or they have been recently started on Reglan. Benzodiazepines are really, really bad for delirium. If they're on benzos or have been started on benzos, get rid of those. And also pain medication. On one hand, you want to treat pain, and patients that are in pain are more prone to delirium, but you can see that patients getting pain medicine can oftentimes become delirium. So if there's a way to treat their pain, and pain medicines, I mean opioids. If you can get rid of their opioids or somehow decrease them or defer them to other drugs that treat their pain, um, it's usually worthwhile. Things that we can do to help reduce delirium and agitation. This is trying to reduce those promoting effects. So, one, treat pain adequately. Like I said, this is a double-edged sword. We don't want our patients in pain, but at the same time, we want to minimize narcotic pain medication because they can promote delirium. You want to maintain regular sleep-wake cycles. So when it's daytime, have the doors open, light on, windows open. When it's nighttime, have the door closed, lights off, TV off, shut the windows. To try to maintain a regular sense of sleep. Get the patient out of bed and moving. Okay, human beings aren't meant to lay around in bed all day. Okay, get them up. Make sure the nurses are walking them. Make sure they're getting them up, sitting them in a chair. Encourage family visitation and orientation. Having people around that they're comfortable with, having people out that they're familiar with, having people that can talk with them about things outside of the hospital are very important. And also this orientation where anybody that goes into the room talks with the patient, tries to orient them, asking them, who they are, where they're at, what the year is, and continue to do so, even if they're confused. Every time you walk in, you reorient them to at least those three things, if not more. And like I said before, limiting the use of drugs that can promote delirium and agitation. Medications to treat agitation and delirium. These are things, at least when you're first starting out as an intern, I would not use until you're, talking with your senior and your senior's kind of running the show and giving permission. Oftentimes, these are medications that, one, in certain patients in certain settings, do promote delirium. And two, are really only used to kind of acutely de-agitate a patient or acutely sedate a patient until the underlying cause of delirium can be corrected, and also to make a patient be able to either undergo their treatment or undergo their workup. So, such as pain medicine. Oftentimes, you give somebody's pain medicine, benzodiazepines such as Versed, which is very quick acting, antipsychotics like Haldol or Seroquel, ketamine given IM or IV, or even at times if a patient's extremely agitated or extremely delirious, they require being almost completely sedated with propofol, with endotracheal intubation, and even with paralysis. This is often seen in the most often when it's done. It's not done very commonly, but it's done in the ICU. But at times, patients will be agitated enough where to get any sort of workup or be able to do any sort of treatment on them, they need to be completely sedated, at least for a period of time, particularly if you're involving imaging such as CTs of the head, CTs of the chest, abdomen, pelvis, and what have you. So we'll go to an example. Like I said, I'm using this example to kind of show your thought process and kind of the steps to go through when you get called for a patient who may be delirious or agitated. So we have a 79-year-old female. She's post-op day 2 from a ventral hernia repair with mesh. It's shift change. It's 7:45. Nurse calls you and she says the patient's becoming more confused. The patient thinks she's at a grocery store and she's talking to her husband, and her husband's been dead for the previous 5 years. What do you do now? So while you're on the phone, some of the questions is the patient stable? I want to know what their vital signs are. So her blood pressure is 95/60. So she has a soft blood pressure. Heart rate's normal, 78. Respirations are 12. O2 saturation is 99% on room air, and the patient is afebrile. Her urine output's been borderline. It's about 250 a shift or so. The nurse says she noticed a change about 10 minutes ago. That's when she was walking in during a report. However, the patient hadn't been checked on for the last hour and a half, 2 hours from the nurse. The last time the nurse was in there checking the patient was sleeping. Any recent meds? The patient did take Protonics right around 5 or 6 o'clock. This is a home med that she's on. The last pain medicine that she got was Dilaudid 0.5 milligram at about noon. So after that, it's for me, I would get on the computer and kind of look up some more information on the patient. So we looked at her vital signs. So her blood pressure of 95/60 is mildly lower than it's been. She's been running anywhere from the 110s to maybe 120s over 80s. This morning, her white count was 12 from 17. She's post-op day 2, and her white count's trending down, which is good. Her hemoglobin was stable at right around 12.5. Creatinine was normal, 0.6, and her electrolytes looked okay. She initially had her Foley removed on post-op day 1. However, it was replaced due to some urinary retention. She had to get straight catheterization 2 or 3 times. Was unable to avoid, therefore the Foley was put back in yesterday. She's on no home medications that will contribute to delirium, no antidepressants or antipsychotics. She is on Dilaudid and Toradol PRN for pain. Her past medical history includes hypertension, hyperlipidemia, gastroesophageal reflux disease, and she had a previous hysterectomy. So in person, go and see the patient, okay? She's sitting in bed. She's pleasant. She's alert and order times 1, so she knows who she is. She thinks she's in the grocery store. She thinks it's 1993. Her husband, when you talk to her husband's not in the room with her right now, but he's down another aisle looking for coffee, but she says he'll be back soon. She is non-toxic appearing. She doesn't look sick. Her lungs are clear. She's maintaining good O2 saturation on room air. She's normal cardiac and she has a regular rhythm. You examine her belly. She's got a midline laparotomy incision, which is well approximated with staples. There's no erythema or drainage, and she is appropriately tender. She does have her foliar in place, and her urine looks dark. So next, you're gonna call your senior and let him know what's going on. After that conversation, the senior said, "All right, let's get a CBC, BMP, EKG, chest X-ray, and UA." Okay. When you get that, her white count is 15, up from 12 in the morning. Her BMP is within normal limits. EKG showed normal sinus rhythm. The chest X-ray showed small bilateral opacities in the lung base, which is read as atelectasis versus effusions. Please clinically correlate. And then her urinalysis, when it came back, was positive for leukocyte esterase, positive for nitrates, and had large bacteria. My working diagnosis at this time, although we don't know, is the patient has a urinary tract infection, likely from the patient getting multiple straight casts and requiring a Foley to get back in. She started on Ansef, which she did not have an allergy to. In the meantime, we're going to minimize her narcotics, so I'm going to schedule Toradol instead of leaving it PRN. And when you look back through the chart, the patient had been asking, the nurse had been giving the Dilaudid PRN as compared to the Toradol, which at that time was scheduled for PRN. So let's schedule the Toradol. We're going to promote sleep hygiene, so lights off, door closed at night. Asking the nurses to try to limit the amount of interruptions and waking up in the middle of the night. During the day, have the lights on, her door open, have the blinds open. You want to get her up and ambulate at least 3 times a day and get her up to the chair as much as possible. We want frequent orientation by staff and encourage family to come visit her and to kind of help reorient her. By the next day, she is improved, but although she still seems mildly confused, she was back to baseline post-op day 4 and discharged post-op day 5. So that's just a case example of some of the thought process and steps to go through when you approach a patient with a delirium and agitation. The big take home I would take from this is just don't take it lightly, especially early on. You need to treat this like this is an acute medical problem until proven otherwise. And then always, even if your patient's not delirious, I would always promote those and try to reduce those factors that do contribute to delirium, such as getting the patient out of bed, reducing pain medicine, sleep hygiene, frequent orientation, encouraging family to come visit. I think all patients will benefit from that and would help even prevent a patient who could have gone in delirium to not do so. So thanks, guys. Can't wait to see you next year.